Hemolysis, elevated liver, and low platelets. That's a clotting disorder, okay? Which can lead to DIC, which is disseminated intravascular coagulation, which can further lead to the patient bleeding out of all orifices and dying. So you can see these are reasons for, as I said, maternal mortality or death. So gestational conditions, in other words, mom's having these problems, hyperemesis gravidarium. So if a patient continues to vomit, she's losing fluid and electrolytes, and she can't keep anything down. So sometimes there's reasons for that. Maybe it's just the first pregnancy and her body has never been pregnant before, so it's getting accustomed to the hormones and such. Or there's twins, triplets, or even more. So one of the things the provider will do is let's send her to have an ultrasound for not only confirmation of pregnancy, but to determine how many babies are in there. So when you have twins or triplets or more, or even other complications, you could have higher levels of HCG, which creates that severe hyperemesis and serum amylase and decreased gastric motility can lead to all those fun things. And usually these patients, if they actually can't keep anything down, they go to a higher level of care, because then therefore not only are they at risk, their fetus is at risk for not growing because they don't have enough nutrients getting through. So they may be shipped to our higher level of care, would be a level 3 hospital. In this area, the level 3 hospital is Krause Irving Hospital. So hyperemesis, obviously it's dry mouth, she's thirsty, she's losing weight. It's not a good thing, okay? So we want to hydrate her, obviously, and then full liquids, small liquids, and maybe give her either Reglan or Zofran. She can be hospitalized for 24 to 40 hours or even longer. We want to give her multivites and vitamin K, IV fluids, and to correct any imbalances. So another reason for that increased HCG levels could be what's called a molar pregnancy. Okay, she's pregnant, but there's no fetus there, and it looks like just a bunch of grapes, and it's like an overgrowth. It continues to um, multiply, but there's nothing really there. So, and that's related, there's many different reasons that this is for. That's why we want to send her to ultrasound and have confirmation of that pregnancy. What can we see? What's going on there? Okay, and the signs and symptoms of something like this would be spotting or hemorrhage. You can see that. We usually the patient is sent to the OR if that is confirmed for D&C. In other words, they go in and they scrape out the contents and clear everything out. If she has contents that are expelled at home, they'll have her bring in the tissue, and so they can look at it. All right. So, but this is very serious as it can lead to choriocarcinoma, which is cancer. So, placenta previa. So, we did talk about placenta previa in lab today, which is implant where the seed itself, the ovary itself, is implanted near or over the opening of the cervix or the cervical os. Okay. Some patients will begin with placenta previa. It was diagnosed, yes, that's where the placenta implanted at. Instead of the outer wall, it planted over the opening, which over the entire cervical opening or cervical Oz would be a total previa. And usually those are diagnosed by ultrasound. Um, and if it remains that way by 35 weeks, it generally isn't going to move. Sometimes it can implant early on and migrate away from the opening. So remember, I also said that these patients are the ones that they're ultimately going to end up with a cesarean section. Placenta previa is painless vaginal bleeding, and it's identified by ultrasound where the placenta is implanted at. Could be a total previa, could be a partial, marginal, or just a low-lying placenta. Remember that the patient is informed of this and educated about it to be able to say to the nurses when she goes in for any sort of complications or even labor into the hospital, don't check the vaginal opening because that can dislodge that placenta and would not be a good thing. So there's unknown causes, they say, but there can be several risk factors. She had previous surgeries, and well, there's more than one um, fetus in there. As I said, painless bright red bleeding. Usually it shows after the 20th week of pregnancy, and she might come in for it and then it'll dissolve itself, and maybe she'll come to the to be checked out because it occurred again. But there's no it's just painless bright red bleeding. There's no other signs or warning signs. Okay. So it also depends on, is she over 20 weeks? That's usually when you see this and when it occurs. So what do we want to do for it? Well, we want to monitor the fetus. How's the fetus doing? If it's is the fetus getting um enough blood perfusion and oxygenation. We also want to look at the maternal vital signs. How's mom doing? If she's bleeding a whole lot, we don't want her going into shock or anything, but usually it's not that much, but we still want to be aware of that. We want to give her IV fluids, assess her O2, INO, how much bleeding is she had, maybe do a CBC and have a type in cross available if we should need it, especially if she's a known placenta previa. We want to have that blood available in case she ultimately does bleed out from it. Yes, an ultrasound is the only thing that confirm it, and no pelvic exams, no vaginal, because we don't want her to hemorrhage, and you don't want to be the person that initiates that. So that versus an abruptial placenta, that's where the placenta tears away from the uterine wall, and again, over that 20th week of pregnancy. So abruption, because it tears away, it results in hemorrhage of mom and baby. So it depends on how much blood she loses. Was it a full abruption? Or was it just a small abruption? Could be the size of a nickel or a dime, or was it a full abruption? And so those determine how well mom and baby are doing as well. So sometimes you don't really identify that until after the delivery. When you look at the placenta, you can actually see the areas of separation and abruption. Things that can do this are usually it's drugs, like cocaine blows it right off the uterine wall. Methamphetamine, that's pretty high right now, and smoking actually can do it. And there are times that it's just a freak thing that happens. So remember that abruptial placenta, how you can tell the difference from placenta previa. Placenta previa is painless vaginal bleeding. Abruptial placenta, when that placenta tears away from the wall, the abdomen fills up with blood, and when you palpate the abdomen, it's very rock hard, board like, and firm. It doesn't, if she's having a contraction, it just doesn't become soft at all. So, and you can see if mom is on the fetal monitors that the fetal heart rate, it doesn't look good. There's a decreased fetal heart rate. Okay, so mom can die from hemorrhage or shock if we don't get her in to deliver her right away, and baby can die as well. So as I said, these are a short cord. Um, Cords are different lengths. Sometimes they can be very long, sometimes they can be very short. Advanced maternal age is considered any person over the age of 35 or lower than 15. Hypertension can do that as well. Pregnancy induced hypertension, cocaine use, or trauma. If mom fell down the stairs, she slipped on the ice, she bumped into something, she had violence in the home, and somebody hit her in the belly. Those are reasons for abruptio. So there's tender, severe, constant pain. With one of my children, I did have a very small abruption about the size of a quarter. They said that's what I woke up from a sound sleep. And that day I had been moving furniture and I shouldn't have been doing that. And I believe that, in my opinion, that was the reason I had that small abruption. And they didn't recognize it. But that's what woke me up out of a sound sleep. I had a small pain in my abdomen. And I went to the hospital and I actually delivered her that night. So there can be total separation, which is tearing and knife-like sensation. Well, we want to look at how much blood loss did mom had, and look at baby too. How's baby doing? Of course, if she had a large amount, we want to increase her IV fluids so her blood pressure doesn't bottom out. Remember, pump up the volume, and we want to give her blood type and make sure she's type and crossed, and give her blood. And baby may be difficult to baby may have complications because of this too. So we may have to resuscitate the infant as well. And sometimes if it happens suddenly and quickly, we're not able to save the baby. So be aware. And like I said, this could be an NCLEX question. I've seen it several times as an MCLEX question. So know this one, okay? So amniotic fluid levels. So amniotic fluid is made up of fetal urine and fluid that's transported through the placenta from the maternal circulation. Okay. The fetus swallows the amniotic fluid and excretes it in the urine. And this is something that it's not, amniotic fluid never is stagnant. It's always circulating. Okay. So what are normal levels? Well, abnormal levels would be polyhydramnios, which is over 2,000 milliliters of fluid. So amniotic fluid index, if a patient's abdomen looks really large, they may want the provider may send the patient to have an amniotic fluid index done. So if you think about a lot of fluid, I can compare it to swimming in a lake versus swimming in the ocean. So if the baby is swimming in this very large amount of fluid, it has a lot of room to move around in, an awful lot of room. So there's things that can happen. Baby can get tangled up in the cord. Yes, there are several complications. And usually that tells us maybe there's some fetal abnormalities, okay? Some things that you might see are congenital hip dislocation, club foot, different things that you might, something's up, something's amiss here, something's off, okay? Um, where it says here obstruction of the GI tract prevents normal ingestion of amniotic fluid. Okay, so obviously there's a problem. Um, RH immunization or ISO immunization. If mom has mixing of the maternal and fetal blood, then we have an issue. history of diabetes, that could be a reason for the polyhydramnios. So in any of these other things that are listed here. So we can also have fetal death because of that. There's a lot of baby can get tangled up in the cord, can strangle in the cord. It can be wrapped around the body, the arm, or even the neck. So that's why we tell mom, pay attention to how often and frequently baby moves, because especially if she has polyhydramnios. Okay, so we want to monitor her weight. So these are how we manage it. Uh, I have seen some polyhydramnios, but not as frequently as I've seen oligohydramnios, which is decreased amniotic fluid less than 1,000 milliliters. Okay, how does it interfere with normal fetal development? Well, remember, if we're swimming in the lake, our arms are out, our legs are out, we got plenty of room to move in, and as far as amniotic fluid, it makes for symmetrical growth of the extremities. But if we don't have a lot of fluid, so you can see things that can happen, like club foot, because the baby's scrunched all up into a very small area and doesn't have room for that symmetrical growth of extremities. Okay. um, there's maybe a problem of kidney development or even urine excretion. IUGR is, so this kid isn't growing right. Intrauterine growth retardation because of this. Okay, it's preterm rupture of membranes could be the cause for it. Mom had a very slow leak and she didn't know that she thought it was, maybe she was just sweating or peeing her pants a little bit. Instead, she had a slow leak and it was premature preterm rupture of membranes. Or there's any fetal anomalies. Usually, a lot of things go back to the placenta. Maybe there's a problem with the placenta. So these are things that you will see, and yes, the infant can die. Okay, where it says pulmonary hypoplasia, in other words, the lungs don't develop like they should. So you can read that same as I can. Okay, so we want to monitor mom and baby more closely. We want to have her come in and make sure she gets all of the testing that she's supposed to do. Maybe put her on more frequent non-stress tests where we monitor the fetus and see how the fetus is doing. And usually with oligohydramnios, she can be set up for an early induction of labor. Okay, so with premature pre-rupture membranes, remember that that can cause a problem because you can get an infection in the amniotic fluid. So therefore, we want to give her antibiotics or corticosteroids like betamethasone, things like that. So ectopic pregnancy. Scarring of fallopian tubes can be caused by a patient with chlamydia or gonorrhea has had a history of. Maybe they had that when they were younger and now they're older and trying to get pregnant. So there's problems here. When the fallopian tubes are scarred, remember those hair-like fimbriae that push the eggs through the tube can't do that because of that scarring. So the egg gets stuck and grows and develops in the tube. That's a problem. Okay, usually it's in the upper third, like it says here, and that tube can rupture, and mom therefore can hemorrhage, and she can die. We don't want that, right? So if she has frequent infections in her tubes, or maybe she previously had her tubes tied, and then years later she decided she wanted to have children, you can have what's called a tubal reversal. Or she had a tubal ligation early and then had a tubal reversal. So anytime you have surgery, remember you have that scar tissue, so the egg can't move easily down through the tube. Or if she had a previous ectopic pregnancy. So again, she'll have scar tissue there. And multiple induced abortions, well, that creates scar tissue too. So there we are again. the DES exposure that happened many years ago, and probably is not so prevalent now, but it was a drug that was used, and it was more prone to women leading to ectopic pregnancy. So know the symptoms, okay? Heavy bleeding. Remember referred pain? Referred pain is shoulder pain. So if she's got heavy bleeding, it causes shoulder pain, rectal pressure. Maybe she's nauseated, she's vomiting, she thinks she's pregnant, but it's really morning sickness, okay? So look for signs and symptoms of shock in these patients. It's not good. It is a true emergency where we have to the remove the egg, maybe remove the tube on that side, okay? If it doesn't rupture, of course, they'll give something like methotrexate, which will stop that fetus from growing, and everything's gets expelled out. Okay. So we did talk about R8 sensitization or ROGAM. So remember, the ROGAM, the mom has to be negative and the fetus has to be positive. We don't want that blood to cross and meet each other. And the reason for that is if it does, let's say mom was in a car accident and she's had some internal bleeding, she needs some Rogan because she'll build up she will build up antibodies, and what will happen is the next pregnancy her body itself can destroy the pregnancy, okay, thinking it's something foreign. So we want to prevent that antibody formation. So it's after she delivers the first pregnancy, we want her to have the ROGAM within 72 hours. So here you can read about it, okay? The first Rh positive fetus is usually not harmed. It's the ones after that. They can cross the placenta and destroy the fetal blood cells, right? So it destroys the fetus. So then we also have what's called a maternal fetal incompatibility, where mom's type O and baby is one of the others, okay? So it contains the antigen, but it's not present in the O blood. So what you'll see here is these babies. Yes, there's rapid lysis of red blood cells. Anytime there's red blood cell breakdown, remember that the babies have an immature liver, so it can't take all that red blood cell breakdown, and it shows itself through bilirubin, higher bilirubin levels, and usually they appear within the first 24 hours. ABO incompatibility. Okay, and you can read about it, like I said. We usually we want to monitor the bilirubin and do phototherapy. They're under the lights, okay? So hypertensive states of morbidity and mortality, 76,000 deaths a year. Wow, that's a lot. So some patients were had high blood pressure prior to pregnancy. Okay, and so what okay, that's a little different. So chronic hypertension, they had high blood pressure prior to. This shows by proteinuria in the urine. Okay, and the cure for this is delivery of the infant. That's how we deliver. That's what we do. So if we can get her to 37 weeks, her blood pressure continues to go up, we might have to just deliver her. Preeclampsia, because eclampsia is the seizures, so it's before that when her blood pressure starts rising after 20 weeks of pregnancy. So these are things that we can have is I move that, and organ damage, whatnot. Okay, so we can have just transient hypertension as well. So during labor or 24 hours postpartum, once the patient is delivered within 24 hours, usually the blood pressure goes back to the pre-pregnancy state, and if it was not high before that. So preeclampsia, these are the parameters for that. Can occur anytime after 20th week. So the cure for this is delivery of the infant, and it can progress to HELLP syndrome, which is hemolysis, elevated liver, and low platelets. So then we got a problem. We don't want it to progress to that. So some of the things that you ask the patient when she comes in, if she presents with high blood pressure, um, so we look to see, is there protein in the urine? Does she have edema in her, all over edema? It's not just in her ankles, but it's in her hands and her face as well. And you can see the parameters for the blood pressure here. And we're, of course, whenever she comes in, we're going to take her weight. Does she see spots or stars? Does she have headaches, ringing in her ears? Any confusion? So any abdominal pain, urine, nausea, vomiting, blood or vomit in the urine. These are all the typical questions. Spots and stars, seeing double, are a patient that has higher blood pressure. You definitely want to ask them that. So we can have mild or we can have severe, obviously, right? We can lead to eclampsia, which is seizures. We don't want that because if mom's having seizures, we need to take care of her. Yes, it's going to affect the baby, but we need to take care of her. So this can because it can lead to maternal death. We can C-section her as soon as possible. So these are the risk factors that fall into that category. All right. So that high blood pressure, if you read at the very bottom, that high blood pressure, hypertension, can lead to placental abruption and fetal and maternal death. So that's so important. Cures delivery depending, is it mild, is it severe? So if it's severe, one of the things that the provider will do is put the patient on magnesium sulfate. Remember that magnesium sulfate is a smooth muscle relaxant. So her blood pressure will come down, but we have to monitor that. She can be placed on that actually during delivery, or I mean, not during delivery, prior to delivery as well. Okay. So what we want to monitor those magnesium levels. So it lowers the blood pressure. You can see how it's given is usually a 4-gram loading dose, and then there's a maintenance dose after that. It's infused very slowly. You have it's given IV piggyback. You have a main line, and this is given IV piggyback. Want to keep track of her urine output, so she'll have a Foley as well. Look at her reflexes, her respiratory rate, because those will be decreased in her fetal status every hour. So this is a drug that can become toxic to the patient. She'll start seeing double, her have no reflexes. So the first thing you want to do is, if she's toxic, is turn it off. Doesn't that make sense? Turn it off. And the antidote for this is calcium gluconate. So we want to monitor her levels, give O2 and calcium gluconate. It should be either at the bedside or readily available if she becomes toxic. So HELLP syndrome, as I said, hemolysis, elevated liver enzymes, and low platelets. This has to do with the liver. And these are the actual signs and symptoms, what you will see, an explanation of it. I'll let you read it, which can progress to DIC, disseminated intravascular coagulation, which is not good. It's very acute. The patient has problems with clotting issues, and she's basically bleeding out of every orifice I had a patient that bled through the eyes, the ears, the nose. She bled out, and as fast as we pumped the blood into her, she lost it. So, and she actually ended up dying. So this is very, you don't want to see this. Okay, the patient went into shock. We were able to save the infant, however. So I'll let you read those so that you know what that is. Because the first time you ever see it, you'll never forget it. So what's an incompetent cervix? So the cervix starts to dilate. In other words, the provider may check the patient. There may be bulging membranes, and it could be early as 14 to 16 weeks into the pregnancy. So it dilates for no unknown reason. Could be a short cervix, it could be other complications. Okay, or the patient had this is why the patient had a history of miscarriages. Our ultrasound can confirm that. So what do we want? We don't want the patient to be upright with gravity. That's the last thing we want. So we're going to put her on strict bed rest, put her in Trendelenburg because that will float the fetus back off from the cervical opening, and give her IV fluids. Tocolysis. Usually tocolysis is something like terbutaline, which is actually a respiratory medication, but it's also a smooth muscle relaxant, and it can decrease any contractions or magnesium, not necessarily magnesium, but usually you see terbutaline given. Cerclage. A cerclage is, if you've ever had a purse that you pull the strings on it and it goes shut, that's kind of what a cerclage is like. It's the provider puts the stitch in the opening of the cervix and pulls the string and ties it shut. So it closes the cervical opening so the fetus can't come through it. And of course, no sex, no intercourse until about 37 weeks when that cerclage is removed. We want the fetus to stay in there. So, patients that come in with this incompetent cervix, they'll have to have a cerclage. Diabetes. You learned about diabetes. You should have learned about it in nursing 111. Okay, so a patient can have what's called gestational hypertension and gestational diabetes, which are two different things. Okay, what that means, gestational hypertension, gestational diabetes, they didn't have these things prior to getting pregnant, but maybe there's a family history of it, so it's actually a precursor that tells them later in life they're going to have diabetes or hypertension. Okay, so diabetes, the patient is likely to have complications during her pregnancy, and there's certain cultures that are more prone to that, obviously. Gestational diabetes actually diagnose over 20 weeks of pregnancy. So maternal risk factors, you can see hypertension, polyhydramnios, too much fluid, macrosomia. The baby is huge because it's living off this extreme sugar here. And so mom is more likely to be set up for a cesarean because this baby's big and she won't be able to pass it. Infant risk, well, birth trauma, that shoulder dystocia, when the fetus turns to go under the shoulder to go under the into the vaginal opening and under the anterior cervix. Okay, the fetus gets stuck there. So these big babies also, they've been living on this sugar all along, and all of a sudden they're going to crash. So hypoglycemia and hyperbilirubinemia, they're big. So when they're coming out of this, if they do have a vaginal delivery, they're more likely to have a lot of bruising and whatnot. So remember that red blood cell breakdown. The immature liver can't handle it, so they're more likely to have upper um, they're more likely to have higher belly levels. Respiratory distress syndrome, just because they're big babies doesn't mean that they're healthy. They might look like a toddler, but they shouldn't. And so they're going to run into some complications, same thing that a small for gestational age baby might run into. Okay, just because they're bigger doesn't mean their lungs are developed either. So these other complications. Okay, as you can read this, I said it already, so you can go through and read it. So these moms get screened. All moms do, okay, early in the pregnancy. And higher risk ones get screened around 24 to 28 weeks. They have a what's called a glucose tolerance test done. We check their glucose level, or if they have a history of gestational diabetes, they're probably going to have it again. Okay, so they have a 1 hour glucose challenge test. I'm sorry, I'm correcting this. So that first they have a 1 hour glucose challenge test, and if it's out of range, then it's followed by a glucose tolerance test, which is a 3 hour. It's sickening, thick syrup. It's gross. Some patients end up like puking on it. They do a fasting 1 hour, 2 hour, 3 hour serums, and to monitor and determine are they in fact a gestational diabetic. Okay. So we don't put these patients on insulin. Generally, they're not on insulin. They are on a diabetic diet, however. And so the thing, because remember, it's just because they're pregnant. So we don't want to give them insulin unless it's truly higher than it should be, like a much, much, much. Um, Usually you'll see we'll send the patient to a dietitian for diet counseling. Okay. So that they know that they're supposed to eat 3 meals and snacks and all that stuff. So in the smaller hospitals, you might be the nurse educating the patient on this, or they could have a program that you show the patient the videos on it and you explain how to use a glucometer, because they may still have to take their glucose every day, and what type of diet. Okay. Like I said, we don't generally start insulin during a pregnancy. That's unusual. Things that the patient can do for exercising, here it talks about. Um, Usually, right after delivery, the patient again returns to her pre-pregnancy, which she didn't have to monitor her glucose. She can go back to having a regular diet. Whereas but remember that this is a precursor, so that later in life she's probably going to end up with diabetes. Okay, that's what it's all about. So I'm just going to let you read this, not go through it, because you should have learned this already, either A&P or in Nursing 111. So cardiac problems. So there's different classes of them, as you can read here. Um, and it could be due to congenital and pneumatic heart diseases, heart disorders, whether or not a patient can handle the stress of labor even. We look at different things. And is she going to pass that on to her fetus? Okay. Um, if mom was born with complications, it could be congenital and therefore pass it on to the fetus as well. So different things that you might see if she has heart complications. Obviously, the heart's not pumping right, so she could have shortness of breath. She could have a cough, a difficulty breathing, palpitations. Can she withstand withstand labor? Infections. Obviously, E. coli is the number one, so we want to make sure that mom cleans herself front to back. The thing with this is, um, in fact, urinary tract infection can cause preterm labor. So if she does have a UTI, we want to get her in and get her treated right away. And also, if she has a history of infections, in other words, she got frequent urinary tract infections before even getting pregnant, she's even more prone to infections now because of that decreased immune system. Okay, so which can lead into kidney problems as well. So if she didn't get treated with antibiotics and it went up into her kidneys, then we got a problem here. So we can have vaginal infections as well. The patient may present with those. Trichomonas, you never want to see that. That's disgusting. It's like green foamy stuff that comes out of the patient. So we want to make sure her significant other gets treated well as well. And again, it can lead not only to preterm labor, these STDs, they can lead to premature rupture of membranes. Chlamydia. Did you know that chlamydia was a flower? Well, we got flowers blooming in Florida because those dirty old men are playing around with those dirty little old women in the gated communities. Oh, sorry, I couldn't help myself there. All right. So chlamydia, newborn conjunctivitis. That's why we give the erythromycin eye ointment. Remember, we don't want these babies to have problems, but it can also lead to neonatal pneumonia, preterm labor, fetal death. So 50% of infants where mom is infected at the time of delivery can have complications. So any STDs that mom has, we want to make sure that she gets treated prior to delivery is basically what it's saying. And gonorrhea as well. Herpes, if she has a herpes outbreak, she cannot deliver vaginally. So we want her treated prior to delivery. So she's going to end up with a C-section. You can pass the oral to the genital. Did you know that? Okay. Syphilis as well. So you can see how all of these can affect a pregnancy. So the infant can have laryngeal warts. Well, that's pretty gross. Okay. There we have it.